Hi, welcome back to Gemma Network Open Live. I'm Seth Truger, Digital Media Editor at Gemma Network Open.
And I'm Rachel Desai, Drama Fishbein Fellow.
Of course, if you're following along, please send us your questions and comments. On Twitter, you can just mention us at Gemma Network Open or respond in the comments sections under the video in YouTube or Facebook. So our first paper today, we have the assessment of jugular venous blood flow stasis and thrombosis during spaceflight. And we've got first author, Dr. Karina Marshall-Goebel with us. Welcome.
Hi, thanks for having me.
Great. So first, introduce yourself. Tell us a little bit about who you are, what your role is.
Sure. I'm Karina Marshall-Goebel. I am a senior scientist with KBR, and I work here in the Cardiovascular and Vision Laboratory at NASA Johnson Space Center.
Okay. So interesting. So I know very little about spaceflight, but apparently there's all sorts of different types of ways that it impacts our physiology and cause medical problems. So tell us a little bit about what you did in the study.
Sure. So this study, it was actually called the Fluid Shift Study, and it's run by 3 PIs, Doctors Michael Stanger, Scott Dulchevsky, and Alan Hargens. So it's a really big study. And originally, we made this study to investigate a recently identified medical issue with long-duration spaceflight on the International Space Station, which is called SANS, the Spaceflight-Associated Neuroocular Syndrome. And it was actually discovered about 10 years ago that astronauts were developing optic disc edema, globe flattening, choroidal folds, and they had blurry near vision. And so one of the hypotheses for these ocular changes is related to the headward fluid shift. So when you go into space, you no longer have gravity pulling on your body and pulling the fluids down into your lower limbs as you do when you're sitting upright on Earth. And so there's a relative headward fluid shift, especially in the venous system. So we wanted to characterize this fluid shift that astronauts experience. And so we looked at the different arterial and venous structures. And of course, this paper then focused on findings in the internal jugular vein.
Right. So interesting. So we've got, if we can show figure 1, it looks like you did ultrasounds of the jugular veins, or left internal jugular vein, and graded the fluid on a scale from 1 to 4, where grade 1 was just forward flow, grade 2 was pulsatile flow that got back to 0 a little bit, grade 3 was stagnant flow, or kind of equal forward and backwards flow, and grade 4 was primarily retrograde flow. Is that right?
Yes, that's correct. So when we took these ultrasound measurements, we did them pre-flight. So in all of the healthy crew members on Earth before they flew, in 3 different positions. So we looked at the seated position, the supine position, and the 15-degree head down tilt. So we had 3 different reference postures to compare to because it's well known that the internal jugular vein is the primary cerebral venous outflow pathway in the supine position, but not in the upright position. And in all 3 of those positions, all the crew members had what we would consider normal flow, grades 1 and 2. So either continuous flow, which is typical of the seated position when the vein is partially or fully collapsed, and then more pulsatile flow that can have respiratory or cardiac variability when in the supine position and head down tilt position. Then we looked at the crew members again on flight day 50, so 50 days into their mission on the International Space Station. And it was a remote guided ultrasound. So of course, the astronauts scan themselves and we remote guide them from mission control. And we found that in 5 of the 11 crew members that we looked at, there was stagnant flow. So no net forward flow. There could be a little bit of movement back and forth or no movement. And then on flight day 50, we saw 1 crew member who had retrograde flow. So of course, going in the opposite direction and flowing from the heart to the head direction.
Mm-hmm. Yeah, and I think figure 3 shows it pretty starkly, where basically you've got the grade 3 flow, which is the stagnant flow, is the kind of bright gold, dark yellow color, and the red 4s are the retrograde flow, with the flow going in the wrong direction. And obviously, this is something that doesn't happen to us on Earth that much. So tell us about the blood clots you found.
Yeah, so as you mentioned, it's extremely rare, especially if you see this in the internal jugular vein, especially retrograde flow. A few case studies in the literature of that happening on Earth, but it's extremely rare. Blood flow stasis, as we know, can occur on Earth, primarily in the lower limbs. So this was definitely an interesting finding, and stasis is definitely more startling than the retrograde flow, in my opinion, because, of course, Burchell's triad, we all know the 3 pillars of thrombosis. Blood flow stasis is one of those pillars. So yes, on flight day 50, we did see that one crew member had an occlusive thrombus in the left internal jugular vein, and this has never been seen before during spaceflight. And when we went back and looked at all the ultrasound data we had collected on the internal jugular vein, we actually showed all of these to two independent radiologists, and it was determined that a second crew member had a suspected thrombus. Of course, we couldn't do compression sonography to confirm it. But so in our cohort of 11, we have one confirmed and one suspected, which is a relatively high percentage. So it's possible that this has been occurring, and we are just now finding it. There's not been that many people that have flown in space, so we're finding new medical findings all the time. But I think it's worth noting that of all the crew members, whether it was a crew member with a thrombus, stasis, or retrograde flow, there was no negative clinical outcomes. All of the crew members were able to complete their mission successfully. We hypothesized that the other venous drainage pathway, so the right internal jugular vein or the vertebral venous plexus and vertebral veins, were able to compensate for that cerebral venous outflow.
Okay. We've got Ahmet Ozen who's joined us, so welcome. We are talking about jugular venous blood flow, stasis, and thrombosis in spaceflight. The one thing that's interesting to me is, I have a fair amount of ultrasound training as an emergency doc. I do some teaching and use it a fair amount in my practice. I'm curious, what kind of, who is doing these ultrasounds and who trained? I'm assuming it's the crew members because there's not a lot of, extra crew. I guess everyone's a crew member by definition. But what level of training do they have? Who's doing the ultrasounds? How do they learn it, et cetera? I guess that's
sure. So, of course, the crew members are extraordinarily busy for 2 years leading up to their mission. Everybody wants their time to train them on their experiments because they're conducting all sorts of experiments up there. But we do get a slot of time to help train them on biomedical basics and ultrasound and how to do ultrasound on themselves. But the great thing is the International Space Station is actually not that far away. So we're able to have remote guidance. So we have trained sonographers in our lab. Dr. David Martin, who has over 20 years of experience in spaceflight sonography, he was the one who leads these sonography session. So he's able to remote guide them, and he has a live image of the ultrasound image. So he can say, go to the left, go to the right, up, down, what buttons to push. So it's all live guided from Earth.
Right, that's interesting. I actually remember seeing a display, I think it was in the Houston airport, talking about space ultrasound a couple of years ago.
That's really cool.
Definitely a unique aspect of using ultrasound.
Right. So I got to ask some questions about the lower body negative pressure pants. Can you tell us about those?
Sure. So the lower body negative pressure is a device that's been around in spaceflight for decades. And there's actually a device on the space station. It's a Russian device called the Chibis. So we collaborated with our Russian colleagues on this study to see if lower body negative pressure could reverse that headward fluid shift. So it's a device that incorporates your legs, and you create a negative pressure in the vacuum using a vacuum, in the pants using the vacuum. And what this does is help redistribute the blood volume, principally the venous blood, back to the lower limb. So this was tested as a countermeasure to counteract the headward fluid shift. And so what we found in terms of blood flow, that it was able to help in some of the cases to help the blood flow return to a normal grade 1 or 2, but not in all cases.
Okay, interesting. We've got a couple more people who've joined us. We got Z Chen, Carr, and Randy Kahn too. And a question from Emily: if they're not wearing the pants, are they wearing compression clothing while in zero gravity?
No, they're not actually. So compression garments is a really interesting topic, and those are principally used when they come back to Earth. So to help counteract any orthostatic intolerance. So it's used to help push the blood back up to the upper body. So what we're doing with the lower body negative pressure is actually the opposite. We're trying to bring in space the blood back to the legs.
Right. So what's the kind of next steps? Is there going to be, is there going to be more testing with, say, lower body negative pressure, use of anticoagulants, more screening for hypercoagulable conditions?
Those are all great questions, and this is such a new finding that it's quite dynamic at the moment. So NASA is absolutely committed to ensuring the health of our astronauts. So they're starting to implement a program where they will screen all the astronauts for jugular veins and possible venous stasis. Of course, this was a research study, so we only looked at 11 crew members, but now they want to look at all of them because, of course, if you see venous stasis, then you're able to use countermeasures to prevent thrombosis or prevent anything else from happening. So we're looking at a lot of countermeasures. Lower body negative pressure, of course, is one, and that's the one that we looked at in this paper. We're also interested in things like resistive breathing devices that help to create a more dynamic pressure situation and increase the flow. We're also looking at venous thigh cuffs as a way to keep the blood volume in the lower limbs. Centrifugation, so human centrifugation, also known as artificial gravity, is something we're looking at on the ground to create a gravitational vector across the body. So we're looking at a lot of countermeasures. This is so new that this is all things that we want to look at. We haven't done it yet, but we're very excited about it.
Nice. Before I forget, we've got some great videos from the actual ultrasound. So first up is the video 1, which is grade 3 flow, showing that the left IJ blood flow is kind of stagnating and not moving as it should be. And this is available. This is available basically as supplemental media on the website with the article, and that's just showing it's just that blood just stagnant on the ultrasound here. And then grade 4, video 2 shows grade 4 retrograde flow, and it's hard to tell from the video, but the crew member's head is on the left, so that blood's going in the wrong direction here, which is probably I guess that's better than a clot, but not what we want, right?
Absolutely, retrograde flow is definitely a surprising finding. And we hypothesize that it's actually due to possibly some kind of obstruction downstream, so in the brachiocephalic vein, because that's usually when you see reverse flow on Earth, that's what's causing it. So it creates almost a detour. So the venous outflow coming from the subclavian vein, if you have a blockage in the brachiocephalic, then of course it would reroute up the internal jugular vein and down some of the other pathways. That is completely a hypothesis, though, so we don't know about any obstruction in the brachiocephalic, but we do know that there's some anatomical shifting when you're in microgravity. So there could be a shifting of the organs that could lead to some kind of compression of the brachiocephalic. So that's a hypothesis that we want to investigate further.
Yeah, and I'm curious, just off the top of my head, that sounds like something like the Chivas lower body negative pressure pants wouldn't work for. Like those would be the wrong trousers for that situation, right?
Yeah, we'll have to come up with some other trousers then.
Right, absolutely. I always just love like mask trousers and stuff. Well, great. Any final thoughts on the study or what else you did here?
Yeah, I think, while the findings can be a bit scary, stasis and thrombosis, I think it really shows that our bodies, the astronauts' bodies, were really able to adapt to their situation, as none of the crew members had any clinical negative outcomes. They were all able to carry out their mission. And even with the retrograde flow, I think it shows how your body adapts, and it was able to overcome by creating a detour for that blood to make sure that it was able to come down. So I think it's fantastic we were able to find this, because we're able then to implement countermeasures to prevent this from becoming a bigger issue. So we're using the International Space Station for exactly what it was designed for, to understand how the human body functions and adapts in zero G, and hopefully it will enable us then to keep exploring.
Great. Any final thoughts?
I actually had a question. I think in the discussion there was mention of the fact that this phenomenon has been examined in the right IJ, or it's been looked at, and I was just wondering, and I also think that there was a mention of oral contraceptives being used to prevent menstruation in the International Space Station. So I'm just wondering if there was any sort of, since that is a risk factor for a hypercoagulable state, if there was any extra precautions that are taken in those situations, or maybe that's something that's so new that it's continuing to be examined right now.
Sure. Yeah, that's one of those things that is so new that we felt like it was worth mentioning, because when you look at all the risk factors that usually are associated with thrombosis, the majority of them don't apply. So surgery, cancer, recent catheter insertion, they don't apply. The only one that jumped out was use of oral contraceptives. So whether or not it played a role, we don't know, but I think it's worth mentioning that it's known to create an increased risk. So that's something that I know NASA is looking into further. And of course, it's up to each crew member whether or not they want to use it. So as long as they're aware of the risks, that's their decision. And the right versus left question is a really great one. So we only looked at the left side in this study, mostly because we had so many targets we were looking at in a very short amount of time. So we decided to concentrate on the left. And there had been previous studies that had looked at the right internal jugular vein when we looked at the literature during spaceflight, and they did not find the same findings. But we do think that it's possible that it's anatomically predisposed to this because, of course, most of the population has a right dominant internal jugular vein. And also, so the left would be smaller, but also, the anatomy of the brachiocephalic has to come across your chest, which would predispose it to being blocked by perhaps the aortic arch. So that's, again, another hypothesis and something we want to look into further.
Yeah, that's interesting. Want to welcome Reggie and Penno who joined us. The one other interesting kind of inside baseball thing about this study here was I loved how you ended up blinding the dates of the study because it's a small enough sample that and a public enough, I guess, population of astronauts and cosmonauts that they would be essentially identifiable health information.
Yeah, and of course, that's something probably that's unique to spaceflight in that our subjects are, celebrities in our world. So, of course, we have to do everything we can to protect their private medical data.
Sure. Great. Well, really interesting stuff here. And the science here is just so fascinating, as you can tell. I've got a dumb smile on my face. Well, thank you for doing this study, and thank you for joining us.
Thank you so much.
Great. Take care. All right, so we are going to move on to our table of contents rundown. First up, we've got a paper, interesting one here. This is a nice RCT from Australia, which is on the other side of the Earth, but still on the Earth.
Yeah.
Where they did an RCT of about 200 people at Sydney at a supervised injection site from 2012 to 2017, and randomized them that if they needed rescue naloxone while they were using recreational opioids, to either intramuscular or intranasal. They did the same dose of 800 micrograms, so 0.8, which is like a pretty reasonable normal dose of naloxone. And of the 200 patients, so about 100, it was 93 in the IM group and 104 in the IN group. 8 required redosing intramuscularly, but 24 required redosing in the intranasal group. And also there were some differences you can see in figure 2, the difference 8 versus 13 minutes in median time to GCS over 13 or higher, and then 77 versus 93 minutes in return to respiratory rate of 10 or higher. So some pretty decent differences.
Yeah, I was sort of disappointed. I mean, I was definitely disappointed, and part of it is, right, we know that intranasal administration of naloxone is it's just it's easier to do, and I think that the kind of unique thing about this study is that it was at a supervised injection site, which we don't really have in the U.S. And so that's another sort of advantage of being able to use intranasal. And I think they make the point that it does still work. It's just at least in this study, it wasn't as effective.
Yeah, I think, the fact that it was at a supervised site, I think is interesting, I guess, as far as external validity in a couple different ways.
Right.
Because, we don't have those here. It's, probably later than a lot of healthcare administered naloxone. But I guess some of the strengths there would be that if it's now that as rescue naloxone, giving rescue naloxone to people who inject drugs or other people with substance use disorder, it's kind of more, representative of what they're going to see.
Right.
And also just, these are recreational overdoses. This is different than, say, when I give somebody a dose of opioids for pain, et cetera. So it does make a lot of sense, and clinically is pretty useful. But yeah, as you said, I think you hit the nail on the head. There are differences, but it's how much do they really matter?
Right.
And I can always give more. There's the old talks, start low, go slow.
Yeah.
You can always add more. And some of these questions, return it. I don't need a patient at GCS 13 when I need them breathing, not necessarily 10 or more.
Well, I was going to ask you actually, since certainly you see this sort of scenario more than I do, if the primary outcome here was the need for a rescue dose with intramuscular naloxone. Did that make sense to you from a sort of a pragmatic standpoint? Yeah,
I think it's hard because I think in these kind of situations, it's hard to know, if you need something to measure it against in order to do comparisons. And there's also, if I'm really busy, if I'm taking care of other patients, if the nurses are distracted and don't see the monitor beeping, or there's a million monitors beeping, so there's all sorts of false positives leading to monitor fatigue or alarm fatigue. It's really tough to know. So, but ultimately, like going back and giving somebody more naloxone isn't that hard.
Right.
And I'm sure a lot of people are going to argue about this, but potential for longer acting things like naloxone nebulizers too. After the first dose, or just kind of being aware.
Yeah.
We see this comes up all the time when we talk about, say, medications for excited delirium, where, I'm certainly a fan of using midazolam, but it has the big downside of needing more redosing, lasting less long, but also at the trade-off of fewer side effects. So it's kind of how much healthcare attention do you need versus safety profile.
Yeah, absolutely. It's always that balance between sort of the pragmatic perspective versus study.
But honestly, I would take from this the main thing is that they both work.
Yeah,
Work pretty well.
Exactly.
But being aware that naloxone intranasal probably is more likely to need redosing. Yeah, that's my takeaway. All right, shifting gears a little bit. Next up is the Association of Punitive and Reporting State Policies Related to Substance Use in Pregnancy with Rates of Neonatal Abstinence Syndrome. So this is interesting. So a bunch of states or counties have basically more or less criminalized substance use in pregnancy is essentially an assault on the child, on the pregnancy. And the question here is there's a balance of, is the idea this punitive, deterring women from using substances during the critical period, which may be unsafe for the unborn child, versus the encouraging women to seek treatment or discouraging women from seeking treatment if they have substance use disorder. And obviously this is observational. They can't answer it exactly, but they did difference in difference approach in 8 different state inpatient databases from 2003 to 2014. And they found that the punitive policies, so basically criminalizing it, was associated with more neonatal abstinence syndrome. So basically punishing pregnant women for drug use led to more harm to the babies when they were born, whereas just reporting, so mandated reporting for substance use but not actual punishment, didn't have a difference. Which is interesting.
Really interesting. Yep. And I wanted to just take a second. So to talk about the methodology. So they used a difference in differences analysis. I'm wondering if I'm not going to put you on the spot, but just sort of a general overview of what that is, only because I think it's a methodology, it's traditionally been used in sort of economics and econometrics, but I see it more and more in, sort of medical journals, especially in sort of the policy purview or realm.
Right. So I am not an expert in difference, but I'll see if I can explain a little bit. First, I'm going to welcome Simel Chichak. Welcome. You are joining us just in time to learn a little bit, hopefully, about difference and differences analysis. But basically, the idea is to try to get some sort of causal inference from observational data.
Right.
And basically, if you have 2 trends that are going along and then something happens, you do an intervention of some sort, like, say, a state policy change, and those trends diverge, you can maybe infer that was causal. Whereas, with a simple something happens, something else happens, and then there's a difference, it's really hard to know if that's causal or not, because there's so many things that are entangled in so much the post hoc ergo propter hoc fallacy. Just because one thing happened after another thing doesn't mean there's a causal relationship there. And especially with opioid and state policy, where there's so many different things that are all wrapped up in it. But with difference in difference, the idea is that if you have 2 trends that are parallel for a while, and then the interaction or potential intervention happens, and those trends diverge at that point, and everything else was otherwise the same, your economists are more happy to say that's more likely to have been causal. Although there are a lot of people who dispute that. And this is, I'd say that my understanding of it and the politics around it is that the economists are very likely to say that this is you're okay inferring causality. They would say a lot of the medical journals haven't caught up with that inference of causality, and I think some of the statisticians on the medical journal side who are more reluctant are saying, well, there's a lot of potential problems here. And some of it, I remember a while ago reading a great tutorial on it, basically showing that you can easily have regression towards the mean confounding causality here. I don't know. Do you know anything else about it?
No, that was a great explanation, actually. So I'm not sure why you were worried.
I don't know. I might be completely wrong.
No, I think that sounds good.
All right, thanks. All right, I think that's enough on difference in difference. Well, what do you have next?
All right, so we have the demographic characteristics of participants in rheumatoid arthritis randomized clinical trials. So this was a systematic review that was essentially looking at the diversity that's represented in racial and ethnic minority groups and women in RCTs, specifically looking at rheumatoid arthritis. And I really liked this review for a number of reasons, but one of which is because I think that there is this conversation about sort of how generalizable are RCTs, even the best well-intentioned RCTs, just because sometimes it's difficult to capture all of the diversity of patient population in the U.S., for example. So as I mentioned, this is a systematic review. They looked only at double-blind RCTs. They found 240 articles, so this was about 77,000 participants. Of these sort of 240 RCTs, I should say, they specifically really honed in on 126 of these that had at least one U.S.-based site. And kind of looked at the enrollment of minority racial ethnic groups compared to the U.S. Census. And I think you can see this in Figure 3, which compares the two. And they found that the enrollment of minority racial and ethnic groups was significantly lower than compared to sort of what is the overall census population in the U.S. So I think it was 16% versus 40%, actually. So pretty big absolute difference. And they also found, interestingly, that the enrollment of men was also significantly lower in these RCTs as compared to the sort of men in the national U.S. Census, so 20.4 versus 28.6%.
Right, that's men with rheumatoid arthritis.
Right, men with rheumatoid.
There's more than 28%
right.
men in
Yes.
Yeah, that's interesting. We usually don't see a lot of men underrepresented.
Exactly.
Usually it's kind of all the typical vulnerable populations that are underrepresented.
Yeah, that was kind of interesting.
Yeah, but yeah, I mean, this is fascinating. I mean, and you know, the way stuff gets studied, if it's studied primarily in white populations, that I don't know, there's all sorts of things that are wrapped up in that. But yeah, all sorts of reasons why it's best to have accurate representation of the patient population in study groups.
Absolutely.
Yeah. Okay. Great. All right. Moving on. You've got another one for us, right?
Yes, yeah. So this is the Association of Physician Characteristics with Perceptions and Experiences of Gender Equity in an Academic Internal Medicine Department. Long name, but very interesting study. So this was a mixed methods, quantitative followed by qualitative study at the University of Calgary, and they were trying to see how physicians perceive the overall climate for women physicians in sort of an academic environment. So the first part of the study, the sort of more quantitative part, was a survey which actually used an instrument called the Culture Conducive to Women's Academic Success. I think it's a 45 question survey, validated instrument. So, you know, asks a whole bunch of questions about sort of this concept of gender equity and culture. And in that part of the study, they found that the culture of the Department of Medicine was significantly worse towards women compared to men. And then the second part of the study was a set of semi-structured interviews. So this was sort of the qualitative component. And they found that, or these interviews, I should say, found that the experiences of junior women were reporting more sort of events of discrimination and harassment compared to actually senior men in the department who felt that there was actually more gender equity. And I should say I missed a figure here. So there was a figure that actually looked at the survey results, looking at gender, but also looking at years in practice, which I thought was really interesting because actually the trends were a little bit different depending on how long a person, male or female, had been in practice.
Yeah, I mean, this is one of those things that I think is both sad and kind of obvious. That if you ask the people who aren't discriminated against, they tell you that things are a lot more equitable.
Right, right, exactly.
Which, is just, there's men have a lot of work to do, unfortunately, in recognizing that, you know, women don't have it as easy as men in academic medicine.
No, it's true. And I just wanted to highlight, there were just a couple of, you know, in the qualitative section, I always love when they put some of the qualitative comments in here because I think it really highlights some of the issues. So one of the quotes in the exclusion sort of theme for the qualitative component said, so this was a junior woman physician who said, "My leaders in medicine suggest that we go to dinner and drinks." And this is sort of in the context of having access to mentors and how you develop a career. As a woman, I don't really like having drinks. That's not a space I want to actually have a professional meeting at. I've got 3 kids to feed. But if you're not available for these events, then you're going to be disadvantaged. So I think small things like that actually do end up playing a role in terms of a culture or a climate in an environment.
Yep. And oftentimes it seems like it's a lot of tiny little things that add up like that.
Yes, exactly. Yeah.
Yep. And then pile it into everything else we know about gender disparities and things like, you know, women who work are more likely to, you know, retain, say, childcare responsibilities at home, don't necessarily have as much time to go to social events where networking happens. And, I mean, kind of the flip side of that, I remember a number of years ago, ASAP was in Chicago. And in some ways, one of the challenges for me was being like, you know, I had a or my wife doesn't come to when I go to conferences and stuff like that, because she understands that like a lot of the benefit of conferences, things like that, is the informal stuff, the networking, the random dinners, the ad hoc opportunities that come up. And she's appreciative and she understands. It's fine. But it was hard. I remember when ASAP was here, I was like, look, I'm going to physically be here, but I'm not really here. I'm away at a conference.
Right.
And if you've got childcare responsibilities the whole time,
it's tough. Really tough, actually. And that's something that I think has been coming up at conferences. Not to go too off of a tangent here, but certainly for women attending conferences too, there's a question of, is there childcare even available? And oftentimes there's not. So little things like that, I agree, do make a difference.
And this has come up at a couple conferences I've been at recently, where the cost of childcare can be pretty high. Everything's marked up at a conference. And there's all these like big giant contracts and stuff. So again, the pendulum seems to be moving forward. I was very happy at the last conference I was at for ASAP, or at our social media meetup. It was at the hotel lobby bar. But one of my colleagues did bring her baby. It was very welcome. Everyone loves the kid. Fantastic.
Well, I'm glad you said that, because I was hoping that we were going to have an optimistic moment there. And hopefully things are changing, or at least there's a recognition of it.
I mean, the good news is there's a baby at the bar.
Yes, exactly.
All right, so next up we've got discrepancies in the registries of diet versus drug trials. So this is an interesting kind of inside baseball journal paper. But we know for a number of years we've had things like clinicaltrials.gov. If you're going to do an RCT, if you're going to do a trial, you've got to pre-register it, so that way I'd say it doesn't eliminate the ability to do shenanigans, to change the goalpost, to move the goalposts, to change what you're studying, et cetera. But at least there's a record of what you're changing. And in this study, they looked at 6 journals, so 5 of the top general medicine journals, plus the American Journal of Clinical Nutrition from 2009 2019. And of the studies they looked at, of 2 of the 9 drug studies on I think it was on weight loss, and 18 of the 21 diet studies, there was discrepancy in registration. Most of it is about the time frame for the primary outcome, or the number of co-primary outcomes, which to me is always funny, because primary means one. There should be one primary outcome.
I agree.
So the fact that there should be number of co-primary outcomes is always amazing to me. But basically just that the same amount of rigor that's happening and allegedly supposed to be happening in drug trials is not happening in diet trials as much.
So interesting. And I have to say, I circled the first line here because that was actually something I just didn't know, that clinicaltrials.gov was actually established in response to the FDA, which I had no idea, and that this was specifically looking at investigational new drugs, but that since then it's actually expanded to include other sort of interventional studies. This happened in the our career's lifetime.
I have a colleague who had a study that was like around this time, and it was this is interesting because I knew I used to work with the primary author of the study who was rejected from a journal, and I knew the editor too. And then it was like, this is a great study, I really want to, but we're past the point where you need to have it registered for something like this, and we can't do it.
That's too bad.
So interesting.
Well, get your studies registered.
You got to register studies, and I don't do a lot of this research, but I did have to register one. I did have to register one study. It was really interesting.
Oh, okay.
It was a whole interesting process. It's also not that hard. And also, even with that, people still change it.
Exactly.
You're at the meetings where people sit there like, do they compare it? What did they do? What was the analysis in this app? This app in the protocol. And this stuff does still get changed. So like I said, this doesn't get rid of all the shenanigans. And I'm actually curious now if people are savvy enough to not put in analyses they know aren't going to look good in the registries. So then if the journal goes back and asks for it, it's now an unplanned post hoc analysis.
Sure. Hopefully we're not introducing any ideas, but...
You know what? If we have that kind of reach, I'll take that as a win. All right. So next up, we've got the association of timing of plasma transfusion with adverse maternal outcomes in women with persistent postpartum hemorrhage. So this is really interesting. So we know some of the data that obstetric hemorrhage accounts for about a quarter of maternal death. There's probably some level of coagulopathy involved. In developed nations, this isn't as much of a problem, but it still leads to a fair amount of morbidity, hospital time, procedures, et cetera. And they basically, as they talk about in the introduction, they took the 2015 trauma study proper on transfusing basically effectively reconstituted whole blood from its elements instead of just red blood cells. and some other prior observational data that suggested that there is coagulopathy in women who have persistent postpartum hemorrhage, whether that's why there is persistent hemorrhage or if that's a complication of the persistent hemorrhage. And basically they found about 1,200 women who had a liter of postpartum hemorrhage or received 4 units of packed red blood cells and had this bleeding despite first-line treatment, the kind of stuff that I learned in medical school, things like uterine massage, surgical repair, C-section, uterine tonic agents like oxytocin. Of these 1,200, unfortunately, there are only 7 deaths, but 62 hysterectomies and about 160 arterial embolizations for blood control. And about half the women got some sort of plasma. Again, this is an observational study. And basically, with all the appropriate propensity score matching, et cetera, there was no difference in outcomes, even with the time to administration, which is interesting.
It's really interesting, and I'm actually surprised. So are people not actually transfusing within the first 60 minutes? Like, if there's this idea that, if it's recommended, and it also kind of just makes sense intuitively, is this apparently something that's not happening everywhere. I don't know.
Yeah, it's interesting. So we've got another viewer, Varun Suriati. Our Slack just crashed, so sorry if I missed that. But we're talking about postpartum hemorrhage and transfusion. And for me, what's really interesting about this question, and I'm not an obstetrician, so I don't have all the answers, but it's interesting to me is, one of the kind of confounding factors in this is that most women do really, really well in childbirth. Most of the time things go perfectly fine, and even when there's a little bit of a problem, initial treatments work really well, and women, bounce back very quickly, especially, good protoplasm, healthy young women having babies.
In the U.S.
In the U.S., right. But then when things go badly, they go badly very quickly. So switching gears like that can be really tough. And I think it's tough because it's basically a dynamic needle versus haystack problem with a really, really big haystack. I guess is my guess. I don't know. That's my guess on it here.
Yeah, no, it's really interesting. And hopefully, I guess we'll see more of this.
Yeah. I don't know. We had talked about a paper months ago about early versus late cord clamping.
Oh, right. Okay.
Yeah, and it was in general we find that early cord clamping is better, but they actually found that basically autotransfusion by doing late cord clamping was better or was associated with better outcomes. And then the question is, like, when do you switch gears and decide that, wait a minute, this is a case where we don't want early cord clamping, even though that's generally better. And this is the kind of stuff that's really hard to study. Yeah, but if you do study, you need to register your trial.
Yes, definitely.
All right, what's the next one?
Okay, so this is assessment of citations of the retracted article by Wakefield et al. With fraudulent claims of an association between vaccination and autism. This was really interesting. So this was trying to investigate whether authors are accurately citing retracted references and using the Wakefield article as sort of a case study of this. And in case for individuals that may not know, hopefully you know, the Wakefield article was published, and it had reported an association between vaccination and autism, which subsequently in many, many, many studies has been demonstrated to not be true, and also that study was ultimately found to have fraudulent data in it. So this was a cross-sectional study. They did a bibliographic analysis of scholarly publications that have cited this retracted article. And it's sort of interesting because the article was partially retracted in 2004, and then there was another retraction that was issued in 2010. So they looked, so they found ultimately 1,153 citing works. And figure 1, I believe, figure 1 is just pretty. Oh, yeah, it's really nice. And it shows the characteristics of the articles that reference to this retracted work. They found that, sort of reassuringly, that most of the articles, so almost 73%, that cited the Wakefield article, cited it in sort of a negative way, or I guess connotation. 9% of the citations were perfunctory, and then 8% were affirmative. So just a minority of them were. And then they looked at, and this is figure 2, the references sort of over time after those 2 periods of sort of partial retraction and then retraction again in 2010. And they found that 38% of the citing works 38% of the citing works were had to do with the partial retraction. So it was like a low number, but then actually after 2010, 71% of the citing works actually documented the retraction. So sorry, I should try to say that again. That actually makes sense. But essentially there was a minority of these citing works that actually documented that there was a partial retraction prior to the secondary retraction in 2010, after which more articles did. But still, not all of them.
Right.
All of them do recognize that. And so I think the point of this is that there's just needs to be work in terms of, from the researcher side, from the publisher side, from the bibliographic database side, to ensure that retracted articles are accurately documented as such.
Yep, absolutely. So I want to welcome Matt Sparks has joined us. Welcome. We are talking about whether or not people reference the Wakefield article being retracted when they talk about it. But yeah, figure 2 is fascinating.
Yeah.
You can kind of see the big switch where for the first 5 years or so, when during the period of the partial retraction before it was completely retracted, that most of the time the retraction wasn't referenced. And then fortunately after 2010, most of the time it was referenced.
Yes.
They did reference the retraction.
But thank you for explaining that in a better way than I did.
Yeah, and then figure 1's interesting because I wonder if somebody more sophisticated could do a difference in difference.
There we go.
But it's kind of interesting because, again, there's observational data, and you can kind of see there's a little bit of a change in 2004 with the partial retraction, and then in 2010, the negational references basically dominate, and all the other less negative referenens, continue to trend down. Which is good because this is, this is one of those things where I don't want to talk about how it was a terrible paper to start with, even if it wasn't fraudulent and bad and all that other stuff.
Right.
And it's just the fact that we still have to talk about it, and that there is still people still refer to that as a scientific basis for a very, very, very debunked theory that was based on not even a castle of sand in the first place, or a house of cards. It's terrible. All right, so switching gears.
Okay. So this is the estimated life expectancy and income of patients with sickle cell disease compared with those without sickle cell disease. So this study was trying to estimate life expectancy as well as income differences in a U.S. cohort of patients that have sickle cell disease. And this was a modeling study, and they used data from actually a few sources, which was kind of nice, right? Because one of the concerns with modeling studies is always the assumptions that are being made and the data that's being used and how complete it is. But this study actually used data from the CDC, from something called the National Newborn Screening Information System, and also published literature. They used a societal perspective to create this model, and they found that the projected life expectancy of individuals with sickle cell in a U.S. cohort was 54 years compared to 76 years in the sort of matched non-sickle cell disease cohort. That the quality adjusted life years in the sickle cell cohort was 33 years versus 67 in the matched non-sickle cell cohort, and that the projected lifetime income was also less in the sickle cell cohort. So it was 1.2 million versus 1.92 million. And figure 3, you can see they also looked at this by sex and age. And really, they found that there wasn't too much of a difference, even in kind of adjusting for that. Although, if you look at figure 3, you'll also see that females overall have an average sort of expected lower income across the board.
Yep. Yeah, it's it's sickle cell is a disease that's very unfortunate. It's in the best case scenario, it can be incredibly painful, but also leads to all sorts of morbidity and early mortality. We see it all the time in the ER, unfortunately, because with just severe pain and access to care for acute and scheduled care in America for that sort of thing is tough. And then I think one of the things is again the needle versus haystack. It's almost every sickle cell patient with sickle cell encounter we have. We see it's a pain crisis, a straightforward pain crisis. But there are a number of very morbid and very fatal complications that happen as well. So you gotta have, as they say, a high index of suspicion. It's tough. So I want to welcome Carl Alberto Artusi, who's joined us just as we're finishing up. So welcome. Thanks for joining us. Join us again next week, Tuesday at 3 p.m. Central Time. We'll talk about some more papers. You can get these papers and more at JAMA-Network-Open.com. Everything's open access and free to access there, including these cool videos and pictures of these ruffled trousers, which is really nice. And of course, follow us on all the usual channels: JAMA Network Open at Twitter, Facebook, LinkedIn, YouTube, Pinterest, Instagram. Yep, we've got Instagram now. And you can get the author portions of these, the author audio portions of these segments on iTunes, Stitcher, and wherever else you get your podcasts. So great. Thanks for joining us. Take care.
Bye.